The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome back to Sky Women's Health Podcast, where we bring clarity to women's health, one conversation at a time. I'm your host, Dr. Carolyn Moyers, board-certified OBGYN, menopause certified provider, and ISSWSH fellow. Today, we're going to dive into the American Urological Association's new guidelines on GSM, Genitourinary Syndrome of Menopause. This has been all the buzz, and if you're following any of the women's health or menopause leaders and thought leaders in this area, you have heard about this. We're going to break down the newly released American Urologic Association guidelines on GSM and highlight the clinical pearls from that and compare it to the 2020 North American Menopause Society position statement on GSM. If you're a clinician or someone experiencing vaginal dryness, irritation, painful intercourse, this episode is for you. The new guidelines are published by the American Urologic Association in conjunction with the Society of Urodynamics, Female Pelvic Health and Urogenital Reconstruction, American Urologic Society, and it's endorsed by the International Society for the Study of Women's Sexual Health and Menopause Society. So that is a lot of medical experts coming together to say, yes, we affirm this is correct. This is what we are really aiming towards. This is how we're recommending treating patients moving forward. And I think with this large collaboration, we're going to reach more physicians because physicians across all specialties who are treating women of this age should be aware of using vaginal estrogen for these symptoms. In this, they looked at over 107 publications. What does the data actually affirm in use for GSM? And so we're going to break that down. But first of all, you might be saying, if you haven't listened to an episode before, what is GSM and why does it matter? GSM is the umbrella term used to describe a collection of signs and symptoms due to estrogen deficiency. And it affects the vulva, the vagina, the urethra, and the bladder. We're talking about vaginal dryness, burning or irritation, painful sex, recurrent urinary tract infections or other vaginal infections, urinary urgency, and incontinence. These are chronic and progressive if they're not treated, but they do improve with treatment. Too often, women suffer in silence, or they're told that's just part of aging, and vaginal estrogen is never provided. So this is so incredibly important because if anybody is curious about this topic, I would encourage you to listen to the recent episode of The Drive. That's Peter Attia's podcast. It's very popular. Dr. Rachel Rubin was just on, and she does an excellent job of covering some of the follies of menopause treatment and therapy, and specifically addresses GSM. All right, so let's talk about some of the highlights. So I was actually chatting with Rachel Rubin. We were texting yesterday as I was thinking through, how does this really differ from the Menopause Society's Genitourinary Syndrome of Menopause position statement. And one of the beefs that I've always had with that statement, and if you've listened to previous episodes, you've heard me say that I really disagree that they discuss using lubricant or vaginal moisturizer as first-line therapy. And basically, this statement abolishes that. Really, low dose vaginal estrogen is first line therapy. And I love that they have a graph in there showing the actual serum blood levels when using vaginal estrogen at the typical doses. And it is lower than menopausal ranges. So it's affirming the very low and insignificant absorption of vaginal estrogen. So, one of the first things in this statement is normalizing the conversation, actually routinely screening for GSM, not waiting for the patient to bring it up. And this is how I practice at Sky Women's Health, really being proactive, opening those conversations. This is definitely what I believe. Personalized, patient centered treatment. So, discussing your options, local estrogen or DHEA or ospemifene. Let's talk about those a little bit. There is insufficient evidence that one vaginal estrogen works better than the other. Your choice should be considered based on your preference, accessibility, affordability, whether you'll use it consistently, whether there's dexterity or anatomy issues that may be a challenge. What does that mean? If somebody has rheumatoid or arthritic fingers, or has some difficulty with positioning, or just with body movement, and has a hard time placing a suppository or the cream, what are we going to do? Anatomically, will the vaginal vault hold the suppository that we're placing, right? If we have some pelvic floor dysfunction. So these are all things to kind of take into consideration. The best vaginal estrogen is the one you use. A low dose vaginal estrogen is affirmed as safe and effective, even for women with a history of breast cancer. Now, you've heard me say this before, but it's nice to see after looking at all of the data, all of these different societies affirm that it is safe and effective. Now, obviously, if it's somebody with active breast cancer, then that's a different conversation be taken into consideration with their oncologist. But I have never met an oncologist who has told me that I cannot give someone with a history of breast cancer vaginal estrogen. So we talked about the fact that there's different forms of vaginal estrogen, and one is not better than the other. So we have a cream, we have a tablet, we have a suppository, we have a low dose vaginal ring, which is the FEM ring. These are all low dose, local, intimate skin therapy. And I don't want it to be confused with the ring, the low dose ring, with FEM ring, which is a higher dose ring that can also raise the blood levels and help with your hot flushes and night sweats and those type of symptoms. Another option is vaginal DHEA. It's a nightly suppository. It's actually an inactive hormone that's converted to an active androgen, and in vaginal tissue, it's aromatized to estrogen. So it gets metabolized intracellularly. And then the other option is ospemifene, which is an oral selective estrogen receptor modulator. And it acts both as an estrogen agonist and antagonist. So it displays anti-estrogen effect on the breast. And both of these do not increase your risk of breast cancer. So all of these therapy options are safe for individuals with breast cancer. They also looked at testosterone and vaginal oxytocin for the treatment of GSM, and there was insufficient evidence to support clinical recommendations of use for either of those. Vaginal estrogen prevents recurrent urinary tract infections in perimenopausal and postmenopausal women, including those with ovarian dysfunction or those who have had their ovaries removed, so basically surgically menopausal individuals, because these symptoms are caused by a low estrogen state, and that happens whether you've had your ovaries removed surgically or whether they have aged out in menopause. There are non-hormonal interventions that can be used alone or in combination with hormone therapy to improve vaginal dryness and painful intercourse. These are moisturizers which are a gel product applied regularly, and it's intended to mimic the natural secretions in an esternized vagina, independent of timing of sexual activity. Okay, so this is what I typically say is for a dry vagina, we want our vaginal estrogen. We want a vulvar moisturizer, which this is really what that's referring to. You're not going to put a moisturizer up in your vagina, but this is a vulva moisturizer and lubricants for any sexual activity to provide that short-term symptom relief from discomfort during sexual activity. It can be water-based, silicone-based, or oil-based. Now, obviously, that helps to increase pleasure and ease of orgasm, but it is symptom relief. And we have to take into consideration, are these ingredients causing any chemical irritant, as well as how does that impact the condom that you're using, or fertility issues if we are perimenopausal, is still in that menstruating phase where we could have breakthrough ovulation. Okay, so they looked at energy-based interventions such as CO2 lasers in the treatment of GSM. And this is something I have really dived into lately because, as some of you may know, we recently purchased a laser in the office. I had a hard time making that decision simply because I felt like the data was fairly weak. It shows, in some studies there's some improvement, but the studies are small, there's short-term follow-up. And this is kind of what it affirmed, that CO2 lasers in the treatment of GSM-related vulvovaginal dryness, discomfort, irritation, painful urination, quality of life, change in bothersome symptoms, satisfaction with treatment and dyspareunia. It really needs to be considered experimental outside of clinical trials. It can be considered for patients who are not candidates for vaginal estrogen or who prefer alternatives to FDA-approved treatments for GSM-related symptoms. So this is where the shared decision-making comes in, and really discussing this with the patients. I have plenty of patients who don't want to use vaginal estrogen, who find it incredibly bothersome, or who are extremely irritated by it. I do plan to get involved in some of the clinical trials with the product. The one that I got was the Mona Lisa Touch because it has over 60 studies and it's been around since 2003 in the United States. So it is the longest standing with the most evidence behind it. And I got tired of my patients going to the med spa and having just anybody put a wand in their vagina and do CO2 laser. So it is an option that I have available in my office for that reason. But the small studies, short-term follow-up, and not showing a significant difference between the CO2 laser and vaginal estrogen cream for vulvovaginal dryness makes it a hard sell for many. The guidelines do affirm that there is no need for endometrial surveillance with vaginal estrogen. What does that mean? A lot of people often ask, do I need a progesterone if I'm using vaginal estrogen? If you're just on vaginal estrogen therapy, no, it's low dose and you do not need endometrial surveillance or surveillance for uterine cancer. We're not having to do routine ultrasounds or endometrial sampling, unless there's abnormal bleeding that presents, right? So for otherwise no symptoms, we're not just routinely doing this surveillance. Okay, and the other thing that they discussed was follow-up. It can take 1 to 2 months for us to see improvement. Occasionally, I have patients even at 2 weeks who are saying, that things are feeling better, but treatment usually improves through 12 weeks. And if a patient doesn't like one option, we can always switch to another option. But just affirming that follow-up is necessary and continued use of vaginal estrogen will be required if you are in this low estrogen state. Now, when might that not be the case? If somebody has genitourinary syndrome of lactation, so they're nursing, and in that time of nursing, they have a low estrogen state and it mimics these GSM symptoms. That is something that is short term, and they may only need vaginal estrogen for the time that they're nursing. But otherwise, if we're talking about true genitourinary syndrome of menopause and a low estrogen state, this is long-term for life. Continue to use vaginal estrogen. The AUA strongly advocates for individualized care and shared decision making, allowing patients to weigh in their values, their symptom severity, their medical history, and really make the decision that works best for some patients. I find that some patients prefer to use the vaginal DHEA insert, which is intrarosa or prosterone, and simply because it's a nightly suppository and they're going to be more consistent with that nightly suppository versus the vaginal estrogen cream or tablet or suppository that is only 2 nights a week. And sometimes they just forget to do that placement. Now, one way that we simplify that is by having them do it on the night that they're changing their patch if they're on an estrogen patch for systemic hormone therapy. What about breast cancer? There's a lot of discussion in the AUA guidelines about a personal history of breast cancer, individuals having a high risk of developing GSM, and sexual dysfunction issues around vaginal health. And oftentimes, these individuals may be on endocrine therapies, including tamoxifen or aromatase inhibitors or AIs. These are common components of treatment for estrogen dependent breast cancer. And why does this matter? Well, 80% of breast cancers are estrogen dependent breast cancers. And whether or not you're going to use a low dose estrogen, it can be offered, but it needs to be offered in discussion with the patient's oncologist. Women who are taking tamoxifen as opposed to an AI are less likely to be at increased risk of breast cancer from the use of vaginal estrogen. The goal of AIs is to actually suppress estrogen levels, while tamoxifen is a SERM that actually competes with estrogen at the level of the receptors in the breast. Now, we don't know about triple negative breast cancers. There's really no data on the use of local estrogen in these, and really a scarcity of any data on local estrogen use in women taking AIs. So there's a lot of question there. But in terms of DHEA and oral SERM, these are both safe and do not increase the risk of breast cancer, as well as vaginal estrogen. We had a study come out recently looking at vaginal estrogen in breast cancer survivors and seeing no increase in mortality or breast cancer cases. So that is all very reassuring for us. All right, pelvic health referrals. I love that they bring this up for women with sexual pain or urinary symptoms that don't resolve with your vaginal estrogen therapy. Referring to a pelvic floor therapist or sexual medicine specialist is recommended. This is really crucial for a multidisciplinary approach. All right, so I already mentioned that long-term, even lifelong treatment is recommended. This is not a short-term fix. I love that as opposed to the 2020 North American Menopause Position Statement on Genitourinary Syndrome of Menopause, that it affirms low dose vaginal estrogen as first-line therapy. There is shared language. The NAMS and the AUA define GSM similarly and support the safety of local estrogen. They emphasize the collaboration with oncologists for women with a history of a hormone-sensitive cancer. They both discuss the use of DHEA and ospemifene. I think that the American Urological Association really explicitly incorporates sexual health into GSM care and more prominently than the Menopause Society. And it's really a welcome shift in addition to vaginal estrogen being our first line therapy. But it really echoes, the same core principles. And I think it is really going to make a difference for many physicians having this in their armamentarium to offer. Because while we do recommend that patients have a genital exam, a pelvic exam to assess what's going on with the labia, the clitoral hood, the clitoris, the introitus, the vaginal tissue. It is not necessary to have that exam in order to start vaginal estrogen therapy. So, what does this really mean for you? The guidelines reinforce how we already practice at Sky Women's Health, or how I already practice. We talk about GSM proactively. We offer comprehensive evaluation, including vulvoscopy and pelvic floor assessment. What does that mean? We are looking at the vulva with a microscope to assess any abnormalities or changes, estrogen deficient changes to the vulva. and assessing the pelvic floor with just a digital exam. Just one finger goes in the vagina and move around kind of in a circumferential fashion, feeling those pelvic floor muscles. Are they tight? Are they painful? Etc. And most importantly, just listening to the patient and finding out what the patient's goals are, what the patient's symptoms are, and what might be the best option for them. And just being brave enough to try a therapy. If you're struggling with symptoms of GSM, whether it's painful sex or recurrent urinary tract infections or urinary urgency or just dryness when you wipe after void, you're not alone and help is available. This new guideline really empowers patients and providers to speak up, to seek treatment, and to not settle with suffering. Thanks for tuning in to Sky Women's Health Podcast. If this episode resonated with you, share it with a friend, colleague, or patient. You never know who might be silently struggling. Until next week, be well.